started. Lindsay, if you want to start recording now. Welcome everyone to September's governing body. We've got one apology, and that's from Louise Lester at Public Health.
Just to note, sorry, Eric, just to note, we've got Nicola's apologies as well, but Kathy's deputising for her.
Of course, sorry, I've forgotten about that. And welcome, Kathy, as Nicola's deputy. Thank you for standing in, and thank you for leading on Nicola's pieces of work. Have we got any changes to the declarations of interest register? Nope, thank you. And Sarah, as of yesterday, we had no questions from members of the public. Has anything come in overnight?
No, nothing received.
Okay, thank you very much. Next, we'll go on to minutes for approval. So if we look at minutes from our last governing body, which was on the 21st of July, a couple of months ago, because we didn't meet last month. If we go through for accuracy, page 1, page 2, page 3, page 4, page 5, page 6, page 7. That's when Sue, you took over from me. Page 8 and page 9. Hessian has raised his hand.
Thank you. Just a couple of typos on page 4. I think the first one in relation to continuing healthcare. There's a comment. I think it's the third line says it's CHC has been funded by CCG. I think during the COVID phase it was funded by NHS England / Department of Health and Social Care. Am I correct? And if so, does that need to be amended? And the next one is in terms of the finance update. Again, I think that's paragraph 1, 2, 3 talks about non-NHS providers. I think it should be non-NHS providers, isn't it, in relation to the payments, if that's all right. Those are the only two that I spotted. Thank you.
Thank you, Hessian. We'll make those changes. Anything else from the minutes? No. So let's move on to the action log. First item has been ongoing for a while is around stroke, and that will be picked up with DBHFT later this morning. Next item, 1984-1, has been keeping on until after the pandemic. 1985.2 has been deferred, as is 1985.4. Hayley, quick update on 2004.1 National Command and Control.
Yeah, so the document's now complete. There's a pre-meeting tomorrow of the audit committee that I'm going to raise with Sue in terms of getting it on the audit committee. So hopefully at the next governing body, I think, depending on timing, we should be able to have that completed.
Thank you, Hayley. Thanks for that. Performance, Victoria. It says complete. Anything you want to update on?
Hi Eric, sorry, I didn't quite get to mute on time. No, not really, because we're picking up performance and other association issues on the agenda, I think, Eric.
Okay, that's great. Thank you. Next one's for Nicola. I don't know if you've been briefed on it, Kathy. Quality and patient safety update, local domestic abuse services.
Yes, we've got something on the next best session.
Brilliant, fantastic. So we can close that down. And communications update has been complete as well, so that can be closed down. I think that's the quickest action log we've had for a long time, and got things closed down. So thank you everyone for getting actions completed. Next, it's chair's update. So that's from from me, and since writing it, sort of locally, sort of things have changed a bit, particularly around the COVID position, and we seem to be sort of inexplicably sort of moving into possibly a sort of second phase. The sort of numbers nationally are going up and up and up. All I seem to hear about on the news is lack of ability to actually get a test when people want tests, particularly affecting clinicians. Again, Radio 4 is a good source of all information, but GPs and intensivists in the same household can't get a test because their daughter's symptomatic, and I think it was something we were going to be aware of when schools restart. There's a great overlap between respiratory illnesses and COVID. Symptoms. Just wondering from the clinicians out there, has this affected practices? Are practices losing staff because of the lack of ability to actually get any tests done? Deepti?
Yes, that's a particular hot topic for us. As of yesterday, we had 3 frontline clinicians off. We had 2 GPs, 1 ANP, and we got 1 nurse. 1 GP, Dr. Bennett, managed to sort of go straight to the test center because there was no tests, and somehow she squeezed through and got a test for her child. We still don't have the result. And there was another GP, and the rest of the nurses couldn't get a test. The quickest they could get was in Bolton, which is not in the next 2 days. So this is a massive problem, and I think it's a very emotive issue for our practice at the moment. This is only clinical staff, and I don't know how many non-clinical staff there are.
Thanks for that, Deepti. And unless we get some local testing sorted out, particularly aimed at clinical staff, I think the situation's going to only get worse. Hessian?
We had a conversation at the start of the pandemic around DBHFT offering the laboratory, provided we could facilitate testing ourselves or possibly in combination with DBHFT. I don't know whether, Victoria, whether we ought to ask this question at the next Bassett Law Collaborative to see if we can come up with a solution, at least for key workers in primary care, secondary care, and social care. Well, social care should hopefully be covered because they have a different portal and access to testing, but certainly for primary care and colleagues within primary care, whether we could have a local solution, please.
Sorry, is that okay to respond, Eric?
Yes, of course.
Yeah, just to say, Hesh, I've already asked the question. I was just checking my emails to see if there's been a response on that. If I don't get something today, absolutely. It just seems to make sense to me to try and do something locally where we can. As you know, we did have a system in place previously that we had to postpone, but we'll see what we can do. I'll chase that up directly with them.
Thank you.
Thanks for that, Victoria. Mr. Kumar, is it an issue in Chesterfield, or?
I think we do have several colleagues, as she was on call last night and she had to go home because her son's come down with a cold, and that's my department, but there are several others as well. So quite a few of the consultant colleagues are staying home. We've got registrars who are shielding, and the testing, there is a testing station at the PROACT Stadium, but that seems to be booked up for about a week now. So it's not too bad. So I'm surprised that they've not given tests at the PROACT Stadium, but asked to go to Bolton, which is a trek across the Pennines, really. So, but I haven't heard that there are major issues with staff being off at the Chesterfield Royal Hospital.
Okay, thanks, Mr. Kumar. Dr. Kumar?
Hi. Yeah, thank you. I think locally the secondary care have got, apparently they got an absence line, so when they ring then they can get tested. I think that the gap is in the primary care. The question I just want to ask to colleagues here was, are you all happy to test within your own organization? I just want that assurance, because last time when we proposed that, not all practices were forthcoming. So what's the individual clinician's view on that? So if we come up with a proposal that whether you would, you would be happy to do a test by yourself. I mean, Deepti, what do you think? Sorry to finger point, but I just want to have a gut feeling, a general view on this.
I think that would be really appreciated because it's only been 1 week since the schools reopened, and this is going to be a massive issue because most people have children. But then where does it stop? Do you just test your staff or their families? And how do you sort of get that related? Because there are some logistical problems there, isn't it? But otherwise, we'd be quite happy because at the moment it is a struggle, and people who are supposed to be on days off or on holidays are asked to come back. So that would certainly help the practice. But how do we go about it? It's mostly children that are getting it. So how would you test your children because they are not your patients, and how there needs to be a system, isn't it?
Yeah, thank you.
There's Mike.
Hi. I think, firstly, yes, certainly at Riverside we will appreciate to test our surgery, but we are not averse at all to test for others in Retford and villages. That's not a problem. The key for us is speed and service for our health staff. But I think we haven't had doctors at this point, but we've had admin staff. Now, be very careful. I think clinicians down is bad. But when we had recently test and trace, we can be very vulnerable. We had one staff who was in contact, and that potentially could have led to the entire of reception at Retford being affected because of the close working as such. And if you get reception down, your surgery cannot function. As such, purely because it's very difficult to spread your receptionists all around the building to try to be as COVID secure as possible. Nobody has the facilities to do that. So it's not just clinicians. We've got to be very careful about our reception staff.
Thanks, Mike. Okay, so we've had a little bit of a discussion around that. Just getting back to my update, flu will be raising its heads. I think most practices and most PCNs have got their flu plans in. I don't know if any practices have actually got flu jabs, have actually got any vaccine in yet. Certainly, it looks like community pharmacists have, and they've been vaccinated certainly from last weekend. As ever, community pharmacists seem to get vaccine first. Dr. Kumar?
Yeah, thank you. I mean, just to give information, really, I mean, we started giving flu vaccination 2 weekends ago, and I physically attended it, and the uptake was about 60%. So if you invited 100 people, about 60 people came to the flu fair. Not a fair, it's an organized event where they got an appointment slot to come. And we also given pneumonia vaccination at the same time. So we were totally surprised at how many people have taken up pneumonia vaccine. So one of the suggestions would be that for other team members too, that when you give flu vaccination, have a list, and if they haven't had pneumonia vaccine, give another pneumonia vaccine the other arm too. So there'll be a better uptake that way. When we send a letter to them, they don't come. But when you're having a pneumonia vaccine in front of them and you say that this will, prevents you from getting pneumonia, almost all of them have accepted to have pneumonia vaccine at the same time.
Thanks, Kumar. And last thing on my list was related to the phase 3 letter, which I'm sure Idris and others will go through in their updates. So I'm going to hand over to you, Idris.
Thank you, Eric. Thank you. Yeah, so a bit of a crossover, probably not surprisingly, between Sir Eric's briefing and my own. Obviously, I touch on flu as well. I suppose one other thing I would add is that the numbers that are entitled to receive the flu vaccine this year have increased significantly, almost double. However, the over 50s will be later this autumn, so they're not the priority group. So in terms of the general public's understanding of this, yeah, it's important that when we get messages out, people realise, if you're over 50 and you're not in one of the other high-risk groups, then actually you'll be in a second tranche in the autumn. We're obviously working really hard on supporting primary care to deliver as many of the flu vaccines as possible. In terms of phase 3, we will cover this on different items on this agenda. So I'll just explain at this point what we're actually doing. So phase 3 is about the return to as much of a normal position as we can be within the NHS, in particular about targeting the elective backlog. So we know that elective patients, the activity there and the treatment was reduced significantly during the whole of the COVID period. So those that are clinically less urgent are now waiting quite considerable length of time. So across South Yorkshire and Bassetlaw, obviously, there are people now that have been waiting over 52 weeks. But from a Bassetlaw perspective, there's only about 10 Bassetlaw patients waiting over 52 weeks. But that is expected to rise as the weeks go by, and we're still trying to work with providers to get on top of sort of the elective backlog. So we are now submitting plans as providers and commissioners, which are finance plans, health inequality plans, activity plans. They're all going through local sort of testing and assurance. Obviously, we're trying to maximise the activity that we can do. And that's looking sort of quite ambitious. And obviously it is dependent over the winter. We'll have the mix of trying to get on top of elective activity, trying to avoid and keep capped down as much as possible the COVID second wave. But there's also the potential for flu outbreaks and sort of other increases in acute activity. So although the sun's shining, we are very much planning for the winter and for the rest of the financial year. On a piece of good news, in my briefing, I make reference to the capital monies that are being made available across South Yorkshire and Bassetlaw, of which Doncaster and Bassetlaw will benefit, in particular on the Doncaster side. And it's really important that we increase diagnostic capacity in particular, because the numbers of patients that can be put through different facilities has reduced significantly. There's Dr. Kumar just mentioned about you can't just invite people in at particular times. You've got to give very scheduled appointments. So it's a lot more difficult to get the flow through. There's cleaning of equipment in between patients and so on. So there is a significant reduction in capacity around diagnostics. So the additional capital investments, a new CT scanner, for example, going into DRI, will help enormously on that, although it will still clearly be a challenge.
Thank you, Idris. Any questions for Idris? I know your hands up, Dr. Kumar. Is that from earlier? Yes. Oh, no. Yes, no.
Yes, it is. Sorry. Thank you.
Thanks, Kumar. Any questions for Idris? Nope, thank you. Then moving on to quality and patient safety update. Mrs. Burke, many thanks for stepping in for Mrs. Ryan.
Thank you. Yes, so Nicola's done a brief paper for you, and I'll just take a few of the highlights. So the patient safety specialist role has come into force now. There was information from NHS England saying that this would need to be in place by, I think, about the 30th of November. Yeah, that's 30th of November. And what Nicola was suggesting was a team approach. This was discussed at the Quality and Patient Safety Committee yesterday, and a team approach was approved. And we thought that we'd just get some further assurance on individuals' sort of competencies and skills around that to see what development they need. I don't know whether, Sue, you want to add to that?
No, not particularly. Nothing particularly to add.
Okay, thank you. The NHS plan was delayed, and that has now been published at the end of July. And and it has refocused, obviously, because of COVID-19. There's some key areas of focus, which Nicola has outlined there. And what we probably want to do is understand where we are as a CCG against those. So there'll probably be some further work at the Quality and Patient Safety Committee, just understanding where we are against them. The NHS England Emergency Preparedness, Resilience and Response Framework, assurance processes. I think a few of you may be involved in this already, but that has come out, and again it's been impacted on by COVID, and it was set out some assurances which we've responded to. So the review of 2019-20, we were fully compliant against them with no outstanding areas. A review of response for COVID-19 pandemic, there was a local review and there's been wider reviews as well, which the CCG has participated in. There was some learning, and that learning has been incorporated into the winter plan, the flu plan and ongoing recovery business as usual plan. And then embedding COVID-19 pandemic learning into the winter plan. This is actually a separate section in the winter plan, although the overall winter plan does reflect COVID-19 throughout each section. We've also seen a reintroduction of NHS continuing care towards the end of August. We add that in from NHS England that we needed to do that. So we've commenced that. Heather Hatt is taking a lead on that and working to ensure that we meet these requirements. There are two main work streams from this, and that's NHS continuing healthcare work deferred between 19th of March and 31st of August, and also routine continuing healthcare referrals from 1st of September. So we're looking at a local system wide approach and to realign ourselves with the Care Act and the CHC assessments, and that we're adhering to them. The CCG will be reporting to NHS England on a fortnightly basis, and we've also put some our specific details within there, the numbers that we've got at the moment. But we are progressing, and the CCG is up to date on the 3 and 12-month reviews. Personal health budgets, so there's a position of where we are now since the 1st of April outlined. And then the hospital discharge service policy and operational model. So we've received the revised discharge policy, and it is reflective of the March guidance which CCG and partners have been working to locally, and it's about having a local response to this. Denise Scott, who's the group manager for Notts County Council, is leading on this across Bassett Law. We will ensure that that is meeting the CHC guidance as well. Excuse me. And infection prevention and control, well, since March and April, there's obviously, as you'll all know, been a focus on COVID-19. A lot of work across the whole patch, but particularly with the care homes, supported by our head of adult nursing. And we've had a lot of cases. Some of those have resulted in deaths as well. The numbers have slowed, similar to what you were saying earlier, Eric, and the cases at the moment don't seem to be as severe with the symptoms as previously. But obviously there's ongoing monitoring and a focus on that. We're monitoring the outbreaks in the homes. Then there's a brief update on the other IPC issues, and routine environmental audits have recommenced now, and the team have just done their annual report, which will probably come to your future governing bodies. And that's the update from Nicola.
Thanks for that comprehensive update. I've got a couple of hands up, Sue and then Hessian.
Just wanted to add on the infection prevention and control. Cathy made reference to the annual report that we actually received at Quality and Patient Safety yesterday, which was looking back at last year, where our performance against the trajectory, particularly around C. diff, was quite higher than we'd anticipated, as a consequence of which we'd had an external review come in to make sure that we'd looked at everything we possibly could, because only one of the cases was attributable to a lapse in care. And I think the positive result of that external review was that actually they didn't identify anything else that we should be doing, and that actually, you know, a lot of the infections were beyond our control. They weren't due to lapses in care. So I think it's just worth noting that extra assurance that we'd received.
Yeah, thank you, Sue.
Thanks for that, Sue. Hession.
Thank you. I think this is a question for both Cathy and possibly Victoria as well. Over the last couple of weeks, I think DBHFT said that they had some difficulty in adhering to the discharge policy as it's been published. I was wondering whether there's been any progress in terms of either understanding why or whether they've now agreed to proceed with adherence. Does anyone know?
Cathy?
I just want to clarify that I'm not aware of any that they've got continued problems, but I'm not aware that they've been resolved either. But I could try and find something out if you wanted me to.
Thank you.
Dr. McGregor Riley?
Thanks, Eric. Yes, it has been raised twice now, and it's been escalated to our Wednesday morning meetings, and also separately, I think, through the discharge team. My understanding is that there is a conversation planned for when Nicola gets back from annual leave to pursue it with DBHT directly. As you know, I think there is some concern that DBHT at the moment is still indicating that full compliance with the stated guidelines is something that they wish to explore further. So I think that conversation is going to happen with Nicola when she comes back from annual leave. Hesh.
Thank you.
Okay. Thanks, Victoria. Anything else you want to come back in with, Cathy?
No, thank you.
Okay, brilliant. Okay. If there's no further questions, we'll move on to Mrs. Tingle, who today has a different background. I'm used to seeing a map of Yorkshire behind you, Hayley.
Well, it's Rotherham actually, but
Rotherham, sorry.
Yeah.
Oh, Rotherham's in Yorkshire.
Well, yeah. Okay, so I'm in Doncaster today, so that's what you can kind of see behind me. So the finance report that is part of the pack, I'm going to pull out the key highlights, but it's the financial regime is kind of in two parts. So I'll take the first part, which is April to September, and then I'll talk about the next part, which is October to March 2021. So I'll just take the key the key points really. The temporary financial allocations are in place April to September. They continue. So we've had notification of those and indeed the allocations as well. It was based on the expenditure at month 11 of 1920 with adjustments for growth. And I think that's resulted in some differences in terms of allocations that we've seen because they excluded month 12, which was March. And there's quite a lot goes through in terms of month 12. So it was a flawed it was a flawed basis in terms of how they set the allocations, but we are getting the top-ups for the first 6 months. Providers are continuing to be paid on a block basis, certainly up until September, and that will continue with the new financial framework when we get that through. It is important to note that we do not have any influence in terms of those payment arrangements, those values. They are determined nationally. Primary care income streams were protected. We got a letter in July to end some of the income protection arrangements, and practices are asked to resume some of the services. Other providers are still being dealt with on an individual basis, but a lot of the non-NHS providers now, whereby they're not part of the national recovery, they are starting to resume work, and we're building those into our forecast position. I think Kathy's just touched on some of the discharge arrangements. The guidance has changed. The discharge arrangements for patients were funded centrally. That will continue to be the case where patients were discharged before the end of August, but the arrangements now have changed from the 1st of September onwards, and we're trying to assess the impact in terms of our forecast position. So just for July only, and it's important to note it's just for July only, we're showing a net overspend of 387,000. On off that, there's 379,000 which relates to COVID. There was a little bit of an error in terms of independent sector reporting, which was in previous months. So it looks as though there's a slight surplus, but that was the position that was reported previously. And we've already got the top-ups for that. The allocations for April to July have now been received as the top-up allocations, and the COVID monies have been received, so that's good. In total, we've actually spent to April to August, we've spent 842 on COVID and 369 in terms of other expenditure. What I'm going to do now is, I think the position up until the end of September is less worrying, because the expectations are that we're going to get those top-ups, the COVID amount funded, the allocations where it's not necessarily been given to us, like primary care and running costs, which it's not been sufficient. But the key risks are from month 7 to 12, and I'll just talk around those very briefly. We are expecting the financial framework. We've been promised that for a number of weeks. We are expecting it to be published this week. We're expecting allocations out last week. It sounds as though they are imminent in terms of being published. There is an emergency meeting at 10 o'clock this morning that staff are on, just getting an update, and I think that's basically the meeting that actually launches the allocation. So that's we'll know something fairly soon. I think the clarity that we now need is we've got a break-even duty in terms of our statutory requirement. At this point in time, we don't know whether the allocations that we are going to be given will cover the costs that we've incurred, and there is some real uncertainty about that. And what we've done as a group of CCGs across South Yorkshire and Bassetlaw, we've done our forecast for the rest of the year, so months 7 to 12, which is October to March. We've aligned our assumptions and principles that we've used on things like prescribing, on continuing healthcare, taking in line the new guidance, and we've also challenged each other in terms of the assumptions that we've used. There's obviously been some gaps because of the inability to deliver any efficiency savings, because quite obviously the environment we find ourselves in, and there is a real lack of uncertainty in terms of investment and transformational programs. So with that all in mind, we've been kind of waiting for this new financial framework, and we will only know what that means to the CCG when we indeed get the allocations. I think there are some real worries across South Yorkshire and Bassetlaw in terms of a financial gap, and what we need to do as soon as we have some clarity in terms of what that means, then we can take actions to take that forward. We are now escalating it as a high financial risk, and we will touch on that in terms of the audit committee. Just the final thing that I just want to just make governing body aware of, we have started work on the financial recovery, because our real worry is now going into 21-22. we don't know what the financial framework is going to look like. We don't know what the impact is going to be into next year. So we've got an opportunity and a window during the autumn time to do a piece of work on reprioritisation and financial recovery in preparation for the next financial year. Work's now started on that, and hopefully it will pick up a pace during the next few weeks as holiday periods come to an end. And in due course, what we'll be doing is taking things through to the exec committee and then obviously through to governing body as well. So at this point in time, what I want governing body to know is because of the uncertainty and the lack of clarity, I think that poses a real financial risk to us in the CCG.
Thanks for that, Hayley. Cheerful as ever.
Sorry, do you know what? I am quite a cheerful person, but you know, when it comes to finances, I'm always a bit glass half full, aren't I?
Yes. Yes, because well, yes, yeah, difficult times ahead, but when hasn't it been? Sue, is there anything you want to come in with?
I think what Hayley said is very realistic, because based on what we know at the minute, and hopefully by the time we get to audit committee, we'll have a bit more information and we can look at it in a bit more detail and see, you know, how we're progressing with things. So, I haven't got any questions on what you've said today, Hayley. It sounds like you're in the right position as far as you can be.
Yeah.
And it's good that we've had the top-up payments for the earlier months, which we were a bit uncertain before, weren't they, about whether we would actually receive that. So that's good news. I only had one really small point, and that was just on the Better Payment Practice Code. Isn't there a requirement now that we pay in 7 days where we can? And do we need to report? Are they wanting us to report on that? Because
I've not heard in terms of reporting. I'll check on that, Sue. I've not heard of the reporting requirements, but obviously with the COVID, you know, there was some real pressure to make sure providers were paid quickly. I'll check with Michelle, but I'd not heard anything. But maybe that's what we include as a separate line for next time.
Yeah, that's great. Yeah. Just follow that up. Be helpful. Thanks.
Thanks, Sue. Thanks, Hayley. Any other questions or points for Hayley before we move on? No. Okay, great. Victoria, performance.
Thanks, Eric. Sorry, I'm finding it difficult to. For some reason, my screen's moved around a little bit. So I'm just going to go through the performance paper, and obviously colleagues can ask questions at the end or interject as they seem appropriate. Obviously, I'm taking the paper as read anyway, but I think there are key highlights that I'd just like to go through, if that's okay. I think obviously we're still in a very challenging situation in terms of overall performance. We've seen particular increases in A&E activity over recent months, definitely getting up towards the pre-COVID activity levels, but still not quite the same. So whilst our performance is edging up towards where it needs to be, obviously as a performer overall at DRI, you can see that they're still not performing at 88.8% and 93.1% for us. However, I do need to emphasise that performance is still comparatively with other local acutes quite a good performance. So we know that across the ICS, for example, the August position, their performance in ED attendances ranged from 91.5% to 83.8%, with an average about 90%. So ours at 93.1% compares favourably. And across the wider region as well, we know that their averaging performance at the moment is around 89%. And there's no national position published due to COVID. So something to definitely keep our eyes on. I think there is a concern that the numbers will continue to rise and create very, very difficult circumstances for ED, given the need for social distancing and IPC measures within ED. So we are working very closely with colleagues across the ICS and indeed DVHT to try to work out pathways of care where we can, supporting implementation of initiatives like Think 111, which I can touch on later as well. So I think something to keep our eyes on. Also looking at the types of patients that are coming in there, it looks fairly similar to the position pre-COVID in terms of proportion of patients in the different banding categories. But there seems to be an increase in the overall categorisation of other, so I think that warrants a little bit more investigation. And looking at just the kind of specialty procedures, it's looking very similar. So I think it's a case of getting back up to pre-COVID levels very quickly, but therefore needing to find alternative ways to support same-day urgent care needs of our community. So moving on to 18 weeks, obviously you've heard the challenges. I'm not going to rehearse that at the moment. Idris has already mentioned the particular challenges that we have around our 52-week waits. 43 patients waiting at the moment, the majority of those related to trauma and orthopaedics and then urology. And again, there is a lot of work happening within the trust to try and alleviate those pressures. We are not looking favourable in terms of comparative with peers across SYB in terms of 52-week waits. And I think there will be a lot more conversation that we'll need to have with colleagues at DBHT about how we reduce those numbers even further. As you'll see from the narrative produced in the report, the Trust Stabilisation and Recovery Plan does produce a high number of activities and plans that are in place to try and address the whole elective capacity issue, and particularly in challenged areas. Trauma orthopaedics continues to be, for example, as well as diagnostics, which again has been touched on previously in this meeting. I think it's also probably noteworthy to say that routine GP referrals to DBHT are still down from the same position compared to last year. So I think what we need to do is continue to work with our GP colleagues as well to try and mitigate the risk of both referrals in where we can and provide alternative pathways for patients to avoid creating even further pressure on our elective capacity across the system. And in terms of progressing that work, there was a recent clinical reference group that was undertaken. We had attendances at that from Mac Ho and Kumar. And further work will be happening now in key areas like trauma and orthopaedics, for example, and general surgery and urology to see what we can do about alleviating pressure of pathways for those particular patients and what learning can we get to maybe manage long waiters a little bit more effectively in our community. Moving on to the diagnostic tests again, we're fully appraised of the challenges that we've got around diagnostics, and we're hopeful that some of the learning that we can take from the national blueprinting work around endoscopy and RICT, for example, will support increased activity in this area. You'll see our waiting list at the moment is over 3,600, and this time last year it was about 2,280. So there has been an increase evidently on that total waiting list. So key areas of challenge continue to be around endoscopy and those diagnostic procedures that require specific IPC and involve a lot more invasive direct contact with patients, which therefore reduces capacity and turnaround time. So lots of activity happening with DBHT, working across the patch with other acutes to try and learn lessons and see where we can improve in performance. Cancer again, although our performance for vascular patients is improving month on month at the moment, we've still got some key challenges around the 62-day standard. We know that cancer referrals are back up to pre-COVID levels now, with the exception of prostate cancer. And providers and DBHT particularly have assured us that they're able to meet the current levels of activity with more face-to-face appointments being available for 2-week waits patients. We've now obviously also resumed screening for all 3 areas as well. So those services are now fully operational. Again, we've got concerns around long waiters, but there is an ongoing piece of work within the Cancer Alliance to support that. Long waiters are reviewed on a week-by-week basis now, so there's lots of intensive review of those cases, trying to make sure that we provide the best care and timely care as much as we're able to. Patient choice remains a concern. We are hearing messages about patients' reticence sometimes to go into treatment and diagnostics as well for cancer, given the requirement around isolation, and people are worried about jobs and incomes, and that's perfectly understandable. So we're trying to find methods to support that as well, and develop guidelines that work across the whole of the SYB area to support those patients to receive that care. Doncaster and Bassetlaw have a high volume of patients also aged over 70. And again, some messages back that those patients are particularly anxious about coming into hospital for services, even where it is on a 2-week wait pathway. So there's potentially some work that we need to do working with our primary care colleagues and our community-based colleagues to maybe encourage those patients to access services that they are deemed to need. But again, that's part of an ongoing process of review that is undertaken. And again, I'm hopeful that the clinical reference group work that we've done will support that. One of the key areas of that has been about developing local consistent comms across Doncaster and Bassetlaw to send messages to patients about the safety of accessing care within acute environments. Ambulance performance, you'll see that most of the standards have been achieved. EMAS total calls were down just over 14%, and the CCG calls down by 13%. However, in a very recent meeting we've had with EMAS, it seems that that trend is now changing, and that we do seem to be having an increasing number of calls and requires conveyancing through to ED from EMAS. And there are some initiatives that we're doing to work with them a bit more closely to see what we can do. And again, this will be part of a wider set of work streams that will be established under the auspices of the redesign of the front door of ED, which I'll go on to later in the agenda of this meeting. Key other issues I want to cover are just letting you know about the improved the IAP trending, improved access to psychological therapies. We did see a definite dip over the COVID period, which is now coming back to normal levels. So that's very positive, and we're going to continue to hopefully encourage that to work, given the fact that we do know that levels of mental health needs have been increased and exacerbated as a result of COVID. So that's good news that performance is coming back on track. In terms of dementia diagnosis rate, I think this again still continues to be an area of challenge for the CCG. We obviously are not at the standard that we want, at the target 78. What we've got is a very high level of variance across the different practices. So, for example, we range from 49.2% to 97.8%. So on average, that's pulling us up, but I think there's an awful lot of work we need to do to understand in primary care what some of those challenges are to support the dementia diagnosis rates to improve. And I think that's a key piece of work that we might want to pick up within the primary care operational group, and maybe at PCC have a further conversation as well. In terms of stroke, I'm not going to go into too much detail. Obviously, we've got the presentation later today. But I think the points that have been raised earlier about the key challenges being the transfer of patients from Bassetlaw through to Doncaster do seem to be persistent. And I think there's some specific conversations that we'll need to have about how do we improve the timeliness of those transfers. Looking at the data, it seems that those delays or the breaches in the transfer doesn't seem to have been alleviated by the implementation of the ACP post. So I think that's an important point that we may want to explore later today with colleagues from DBHT. I think the other thing I just want to highlight is the performance around health checks for people with SMI. Again, I think there's room for improvement in our performance on this. And again, looking at the data, there seems to be some considerable variation across primary care in terms of the performance against this. And so I think in a similar vein, we need to do some more exploration with our PCNs and our practices to understand better how we can support this activity. Again, as we know, serious mental health has been exacerbated under COVID, so it's very important that we try to maximise the opportunity to do the full health checks for people. What we are finding is that although there are, obviously you'll know that there are 6 elements for the health checks, lots of these elements are being completed, but we're not getting the record of all 6 being completed for all patients. So we do think there's an issue of data capture as well in here that we need to follow up on. So those are the key points that I think I wanted to raise today. Are there any specific questions about anything that I've discussed so far?
Okay. Thanks for that comprehensive update, Victoria. Any questions for Victoria? No, thanks, Victoria. I think by covering everything, you've not left any room for any questions. Could we now move swiftly on to the planning process?
Yeah, Eric, is it okay if I kind of combine the planning process with the phase 3 guidance, because they are intimately linked? Is that okay?
Of course it is, Victoria.
So I think what I'll just do is talk through some high levels about the planning guidance and what our expectations are, because as Hayley's already indicated, in terms of planning, it's very much a process that's been driven really by this phase 3 guidance. So I'll just talk at high levels, and again, if people want to interrupt me at any point, please feel free. So as has been indicated, we've moved now from the level 4 national to level 3 regional incident assurance, and that happened from the 1st of August. The focus has been really on 3 key elements. One is about the accelerating a return to near normal on non-COVID services, maximising the period of time that we've got now until winter, where we know that we could have particular challenges around flu and any resurgence of COVID. And again, Eric, you've already indicated rising numbers. The second key area of focus is around the preparation for winter. And then the third key focus has been about embedding the lessons learned from phase 1 and 2. The focus being on supporting staff, recognising the impact that working through the COVID pandemic has had on staff, and also addressing health inequalities that we recognise have been exacerbated as a result of COVID, and promoting prevention. So I'm just going to go through some of the key areas that have been highlighted for moving to this near normal or pre-COVID state again. The key areas that we've been asked to comment on and provide assurance on are related to mental health and LD, cancer, urgent and emergency care, primary care, elective activity and community-based activity. And we've been required to submit assurance around delivery of performance to long-term plan ambitions and bringing services back online as part of a